Yep.
Okie dokie. Great. So thanks everybody for this opportunity to speak with you. As TC mentioned, I'm a postdoctoral research fellow. I have affiliation with the Harvard Chan School of Public Health, the Department of Epidemiology, but my primary appointment is actually at the Division of Population Science at the Dana-Farber Cancer Institute. And while these sessions have really focused a lot on using tools like Earth Engine and specifically Earth Engine to do some really complex geospatial processing, I wanted to, in this talk, introduce some motivations for the types of questions that we might choose to study. And so, the talk that I'll be giving today is basically thinking about geospatial analysis as a tool for addressing cancer disparities. And I'm going to make the argument that I feel it's very underutilized. So all of you with this great expertise, I'm hoping I might be able to convince maybe one or two of you to think about cancer as a possible way to apply these methods. So first, I want to get us all on the same page in terms of just what we mean by cancer disparities. And the way I think about it is really cancer disparities are inequalities in cancer outcomes, including disease endpoints like mortality and incidence, but we can also consider access to specific treatments and screening as well as possible things to look at here. And the key idea is the reason we call them disparities is because they are unjust and preventable. And we can typically this is done by comparing more to less privileged groups. So you can think of this at the level of a country, so comparing high and low income countries. You can think about this in the context of a particular geographic area. So I'm from the US, and so white and Black Americans have very different rates of cancer. And then we can also think of this, of course, in terms of socioeconomic status and poverty. So in this, so this is a map of the world, and these are incidence rates of all cancers that have been compiled by the International Agency for Research on Cancer. It's kind of a WHO body, and so what we see is actually that rates of cancer are highest in higher income countries. So we see North America, Western Europe, Australia as seeming to have very high burdens of cancer incidence, and then parts of the world where there are more low and middle income countries, places in sub-Saharan Africa, Southeast Asia, seem to have lower rates of incidence. There's clearly major differences, geographic differences that we can see. The picture changes, however, when we look at mortality. So whereas in the last figure, we saw incidence was really high in higher income countries, we see actually that mortality is higher in some of the poorer parts of the world. And so we might want to think about addressing this. Why are these differences there? And so this geographic analysis gives us some insight into identifying these problems, but it doesn't tell us how to respond to them. So if we drill down a little bit more, and so thinking about cancer disparities in the United States, there's a recent report that if you're interested in this topic, the American Association for Cancer Research produces a report on cancer disparities. And so the figure that I want to kind of pull out here is that African American men and women have over twice the risk of dying from prostate cancer and a 39% elevated risk of dying from breast cancer. And I picked prostate cancer because it's a cancer that I work on a lot and have been thinking about this with mentors of mine. And so in this panel on the right, what we see is these are rates of fatal prostate cancers. These are prostate cancers that are clinically very aggressive and that people tend to die from. And we see that despite the fact that among both Black and white Americans, these mortality rates have been dropping pretty precipitously since around since 1990 or so. But the gap has persisted pretty much over this entire period of time. So that suggests, like, why, if treatment's getting better for everybody, why are we seeing these gaps? And so these rates are measured in registries. And so in the US, these registries are published at the state level, but you can also access them through the federal government's National Cancer Institute. And so that's where some of the data that I'll be presenting today comes from, these registries that are collected over time. So now we kind of have an understanding of what these disparities are. We kind of know where we can get data to measure them. Now, how do we think about responding?
Thank you.
responding to them.
Exactly.
And so here we have a kind of complex figure that really is to help us wrap our heads around how many things we have to really keep track of. The other reason I like this figure is because it's really pointing to aspects of the environment, things that we can measure with our geospatial data, things that we know how to analyze using tools like Earth Engine. And so we see myriad components of the social environment, things like racial composition, things like social capital, socioeconomic measures of our neighborhoods. And then we also see aspects of the built environment. Are there walkable green spaces? Are there land regulations that restrict where we can live? Are there public gathering places where we can play with our friends and family? And all of these could conceivably influence some of the lifestyles, things like dietary patterns, things like obesity and physical activity, that can impact along the entire continuum from when a person is at risk of cancer to when they get their diagnosis to when they start treatment to when after treatment they're followed up to make sure that they're managing their cancer all the way till their ultimate survival or mortality endpoint. So this is clearly a really, really complicated kind of network of factors that are interlinking in all kinds of different ways. But it really emphasizes the point that we really have to think in terms of multi-level strategies if we want to be able to intervene on disparities, because we know that different groups of people are going to have different exposures to these different environmental characteristics. And I think a lot of scientists would agree that our job is to inform policymakers about who is at risk, where they're located, which is inherently a geospatial attribute, and most importantly, how to intervene. What is the policy that we need to do in order to address these disparities? So now that we've kind of talked about disparities, we can shift gears into things we know a lot about. So what can we do with geospatial analysis here? How can we bring these tools to bear to address this important public health problem? I was able to find some data from a recent review, actually, on the use of geospatial analysis for cancer research. And what this figure basically did was it's illustrating the topics of all of the publications from major cancer centers in the U.S. in terms of what their research questions were. And so one thing that they found that's quite interesting is that the vast majority of geospatial cancer research has been published since 2000. So again, this is a growing area that people are starting to get interested in. The other thing that we kind of take away from this figure is a lot of it is descriptive. Descriptive studies are important. Like we need to know, so it's great to have these maps that show us that, this county has an elevated rate of some cancer that might prompt some kind of a, a targeted strategy to understand what's causing that elevated risk in this county versus that county. But it doesn't really provide us enough information to be able to really act. As we saw in those maps of the world, we don't know what is causing the differences between Zimbabwe and the US in terms of those cancer disparities. There could be a lot of different things. And so there's clearly a gap there that we need to think about questions that we can translate into policy. The other thing that I wanted to mention is, and this isn't quite captured in this figure, but a lot of these studies tend to focus on cross-sectional measurements. So what that means is that the environmental characteristics that they're looking at are being measured at the same time as the cancer endpoint. And that's problematic, again, if we're trying to think about a policy strategy, because we don't know which came first. We don't know if people who have cancer are somehow being influenced by that environmental exposure. The cancer is causing some kind of a phenomenon, or the other way around, that it is the places that they're living in that are causing it. And the other thing is that we often use multidimensional figures like socioeconomic status, which is capturing income, wealth, education, all kinds of things. And that's useful to be able to measure the disparities, but it's hard for us to be able to actually figure out where to intervene. So how can we use tools like Earth Engine to help us think about help us address these problems and these challenges? First, Earth Engine has made it super easy for us to capture long-term geospatial measures of specific modifiable neighborhood characteristics that we might think are associated with cancer disparities. And one of these single components of like an aggregate socioeconomic status measure gives a policymaker like, okay, I don't have to think about all of socioeconomic status. I can think about this one piece and I can design a policy around it. The second really important thing that we often forget about, honestly, as an epidemiologist, is that when I use a geospatial measure, I'm capturing two things. One is I'm capturing some aspect of that exposure, whether it's green space or air pollution that might have some impact on health. But I also know where that exposure is happening, and knowing where to act is an incredibly useful thing to know if we're trying to reduce inequities. And so some examples of this are trying to understand geographic access to cancer services. And we can use Earth Engine to estimate travel time at scales that were previously impossible. And knowing both where the gap is in accessing services, along with characteristics of who this population is, should provide sufficient motivation to be able to act and to propose a policy to address that gap. And then the last thing that I want to really emphasize is that these geospatial data sets are often globally available. So coverage is there for every country in the world. And I work with a number of investigators in resource limited settings. And so it's great for me to be able to say, hey guys, here's a huge data source that you don't need to pay somebody a million, tons of money to get. You don't have to invest in really expensive data collection streams. You can start using this right away. And that's really important too, in terms of addressing some of those gaps in access to data, high quality data to answer these important questions. So now I'm going to shift gears to draw on some examples from my work where I've been able to try to apply some of these new geospatial analytic tools to address some of these previously existing gaps in cancer disparities research. So the first study that I want to present is a project I did with several collaborators at the Harvard Chan School of Public Health and the Brigham and Women's Hospital, linking long-term measures of residential green space to a cancer registry database of Black and white men with prostate cancer. So first, just to kind of provide some definitions here, when I talk about neighborhood greenness, this term is used to refer to the natural green vegetation in the spaces where we live and work. And so I'm going to use examples from Boston. That's a city I live in. But we can think of a park as an example of neighborhood greenness. This is a park or a destination where people can come together. It's a large green space. And so this could be an example. Another example could be pathways through a city that are very highly green. So the Emerald Necklace is a series of interconnecting parks in Boston where there's these beautiful, beautiful green spaces, lots of trees, lots of green areas by a river that people can sit or use to commute back and forth from work. And this would be another example. And then another aspect of neighborhood greenness that's a little harder to measure using some of the tools that I'm going to show you is actually just the greenness that we see. So when you're looking outside your window in Beacon Hill, which is kind of a wealthier neighborhood in Boston, even things like street trees or potted plants would be example of greenness exposure. They're not necessarily spaces, but they could be providing some of these benefits. So it turns out that there's actually been a lot of growing interest in research on the health benefits of green space. And so thinking about neighborhood greenness as an exposure, there's actually been a lot of evidence linking this to a number of behaviors that we might expect to influence health. For example, there's been a lot of really strong evidence linking neighborhood greenness exposure to a variety of mental health outcomes. So lower rates of depression, lower psychological distress, and lower cognitive fatigue. And as we know right now with the COVID epidemic, like maintaining mental health is really, really important. And so if neighborhood green space exposure can help us with these, we could think that these would have far-reaching consequences for a variety of health outcomes, including cancer. Another mechanism that's being explored is chronic stress. So whether comparing people being exposed to high levels of neighborhood greenness versus low, whether there's changes at the physiological level related to chronic stress. So one marker that's used is allostatic load, which is essentially a multi-dimensional index. I know I was dumping on it a second ago, but this multi-dimensional index is capturing aspects of physiological response to stress. So these are neuroendocrine hormones, these are cardiometabolic pathways like glucose tolerance, hypertension, etc. And they found that neighborhood greenness is associated with lower allostatic load. In addition, neighborhood greenness has been shown to be associated with lower inflammation and increased immune function. And inflammation and immune function are biological processes that have been shown to influence the risk of cancer progression and initiation. And so this could be another important pathway through which neighborhood greenness exposure might influence cancer risk. And lastly, there's pretty good evidence showing that neighborhood greenness is associated with different lifestyles. So increased levels of physical activity, lower body mass index or obesity, and also interestingly, improved social cohesion. And so for prostate cancer, these are typically men who are older age. And so if they're if living in neighborhoods with more green space is giving them a stronger sense of community, that might also influence their risk of mortality with the disease. So it turns out that neighborhood greenness also is unequally distributed by race and ethnicity in the US. And so this was a really nice study published by Joan Casey at Columbia that in this, what this figure is showing is every one of these lines, these vertical lines is a census tract. And they looked at the level of normalized difference vegetation index. This is a satellite derived measure of greenness that I'll talk about more in a second. What this is showing is that as neighborhood greenness in 2001 increases, the racial composition of the neighborhood shifts to be more and more highly skewed towards white Americans. What this panel on the right is showing is the change in NDVI from 2001 to 2012. And so what this is kind of showing is that those patterns stayed pretty constant over the period of time. And so because this is unequally distributed, we might think, hey, might a policy to equalize neighborhood green space between racial groups, might that lead to some change in the mortality disparity? So that was kind of the question that we're trying to answer here. And in order to do that, we started by taking data from the Pennsylvania Cancer Registry. So essentially, this registry provided data on men with prostate cancer diagnosed between 2000 to 2015. And we followed those men for up to until their death from any cause. We stopped follow-up at 10 years or on January 1st, 2018. And whichever of these came first was how we defined the endpoint for these men. And so because this was a population, what we call a population-based registry, these men are really being taken from oncology care centers and diagnostic facilities all across the state. So we feel like we have pretty good coverage. We're not really missing a lot of cases. We excluded men of other races. We wanted to really focus on Black and white men here because that's the greatest extent of the disparity. And we excluded men with in situ cancers. These are non-clinically meaningful. We did have some men missing data that we had to exclude as well. But we still ended up retaining a fairly large sample size of 128,568 people. And we had residential addresses for all of these men. In terms of measuring residential greenness, we actually, I went into Google Earth Engine to do this. And so I was able to pull NDVI measures from the MODIS satellite product. And so this is available at 250 meter resolution. And so we could sort of figure out where the residential addresses were and assign the NDVI, this normalized difference vegetation index measure of green space, to the men at that in that pixel to assign that NDVI value. And so we did this for because men were diagnosed over different years. You can imagine this would have been really complicated, but with Earth Engine, we were able to just pull all of the rasters for all of those years and make sure that we were aligning those correctly with the diagnosis year. The other thing that you can see in this figure on the right is that, you know, Pennsylvania is not uniformly green over the entire course of the year. And so what we did was we took a seasonal average of the least cloudy images in January, April, July, and September for the year of diagnosis. And so we linked this to diagnostic year NDVI as that measure of green space. So in terms of our analysis, we wanted to really estimate the incidence rate, or so the incidence rate of mortality. And so this is a commonly used epidemiologic measure of neighborhood greenness and mortality. And so in order to estimate what are called hazard ratios, so the ratio of the instantaneous rate of mortality at a given point in time over this entire period of follow-up, we used Cox proportional hazards models. So these are commonly used models to estimate these things. And we were able to obtain 95% confidence intervals to give us some precision around that estimate. The other sort of higher order question we wanted to ask was sort of trying to get at that policy question. If we could intervene in some way, would that have an impact on racial disparities? And so effectively how we operationalized this was to try to model the impact of a policy to set NDVI values, to set neighborhood greenness to specific thresholds. And so for the rest of this study, when I talk about a racial disparity, what I'm going to be referring to is the excess 10-year mortality per thousand among Black compared to white men with prostate cancer under these three scenarios. So in the first scenario, we kind of were looking at a sort of a negative policy. So what if everybody had neighborhood greenness that's experienced by the NDVI level of the 25th percentile of NDVI among Black men? The second scenario was to just allow everybody to take the NDVI value that they actually had in the data. And then the kind of optimal policy was what would happen if everybody in the data set was exposed to the 75th percentile of NDVI observed among the white men. So as kind of the ideal scenario. We were then again able to use Cox models to estimate these risk differences. So this excess 10-year mortality per thousand among Black compared to white men. And in all of these models, we were adjusting for important sociodemographic and clinical covariates. And we were able to obtain these risk differences and confidence intervals using bootstrapping with 500 repetitions. When we had these different scenarios, when we got the risk differences from these different scenarios, we could estimate the percent of the disparity eliminated by fixing NDVI to the 75th percentile to get a sense of how much the disparity would change if we were to do this hypothetical intervention. So these are the first kind of results that we found. And so just to orient you, these are hazard ratios, so the relative rates of mortality. The CONT is referring to the association for a 1 interquartile range increase in NDVI. And then these are quintiles of greenness, which is oftenly done also in these types of studies, where each of these is the relative rate comparing men in, for example, Q2 to Q1. So so taking this away, basically, if you're below the 1 line, that means it's a good thing. It means your rate is lower. And so what we're seeing here is that there's a pretty strong inverse association whereby men who had higher levels of greenness on average had lower rates of all-cause mortality. And this P for trend is statistically significant, we would say, at the 0.05 level. Looking at cardiovascular disease mortality, we find even stronger inverse association. So comparing quintile 5 to quintile 1, that's something like an 18% lower rate of cardiovascular disease mortality, comparing men in the highest to lowest quintile of greenness. And again, the P for trend is significant. And then for prostate cancer, the trend is significant, and all of these point estimates are below 1, but this dose response isn't quite as linear. But anyway, I think this is providing pretty strong evidence that, hey, there might be something interesting going on here, where these men in these higher levels of greenness are experiencing lower rates of mortality among those with prostate cancer. So in this table, what I'm showing you are the results from that sort of policy simulation. And so again, to orient you, this first line is basically what the observed mortality disparity is comparing Black to white men. So on average, there's 29.3 excess deaths per thousand among Black compared to white men, if there were no intervention. And then as we sort of implement these different interventions, as we would expect, the disparity is highest when NDVI is fixed to that value observed among the 25th percentile of Black men, gets a bit lower in the observed data, and then is the lowest when everybody is exposed to the 75th percentile for white men. And that results in about a 5% reduction in the disparity. Although it's important to note that these confidence intervals are all overlapping, so these are not really strong findings. But there is still a modest reduction in the disparity. When we look at cardiovascular mortality, interestingly, what happens is the disparity increases when greenness is fixed to the highest level. And unfortunately, in the interest of time, I can't show this. But what's happening is when you look among Black compared to white men, all of these health benefits that we saw on the last slide appear to be accrued by white men, but not by Black men. And so that's resulting in actually a net increase and a pretty substantial, actually, relative increase in the disparity. For prostate mortality, we sort of see patterns more similar to that for all-cause mortality, where the disparity decreases by 23% if we were to do this hypothetical intervention to fix neighborhood greenness for everybody to the highest level experienced by white men. So what did we learn here? I think this provides some data in support of this hypothesis that residential greenness might be associated with some factors, at least, related to lower mortality within this group of men with prostate cancer. In our kind of simulation policy analysis, we did find that fixing greenness for all men with prostate cancer was associated with modest declines in the racial disparity in all cause and prostate, but not cardiovascular mortality. I should be clear about that. There's certainly a number of limitations of the study. We didn't have data on individual lifestyle or behavioral risk factors. We didn't have the ability to really look over time because we didn't know if people moved. 10 years is a really long time. And so, we should take this with a grain of salt. But that being said, this does, you can think about this in two ways. One is in the policy context. This is suggesting that maybe if we were to design an intervention around neighborhood greenness, it might make some small, modest contributions to reduce Black-white mortality. Again, acknowledging that those confidence intervals were very wide, and certainly we may need to better understand why the cardiovascular mortality those benefits seem to be accrued among white and not Black men. So that would require some thought. But the other way to take this would be to think about, hey, we've identified a geospatial measure that's associated with prostate cancer mortality above and beyond all of the normal things that people choose to adjust for. And because it's location-based, we could incorporate that along with other risk factors to be able to better identify those men at elevated risk of mortality. So that was kind of a one case study. Now we're going to switch gears pretty dramatically to think about a very different application of application of geospatial analysis in the context of more macro level policy thinking. And so this was a study that I worked on with colleagues who have expertise in health policy and health economics. And this was a study to think about balancing trade-offs between equity and efficiency when deciding where to place cancer services. And this was kind of in a global health kind of arena. So this is going to be using data from low and middle income countries. So the motivation behind this was there's really a growing recognition that cancer services need to be expanded pretty rapidly in low and middle income countries in response to lots of changing demographics. A lot of these countries have very young populations that are going to be aging in coming years. And so with aging, age is kind of the strongest correlate with cancer risk. And so it's coming. And then the other piece of this is that a lot of these countries are urbanizing rapidly. And that comes with a lot of changes in lifestyles and behaviors that have been associated with a number of chronic diseases, like cancer, of course, but also cardiovascular disease and diabetes. So in recognizing that we need to scale up cancer services, we have to make some decisions about where to place these services. And the way these decisions are generally made is focusing on efficiency of service. And I'm using efficiency in the sense that For example, if we were to choose to place cancer services in an urban area, that would bring down costs because there would be a lot of people who would be using those services. So that means the cost per test is going to be a lot lower. But if we only put cancer services in an urban area, that's going to make it harder for folks in rural areas who often experience a number of other barriers to accessing cancer services. And so that's going to create problems for them. And so we might really be concerned about equity there. So the kind of the thesis here was that we should think about using geospatial data, and could we use geospatial data and analytic tools to provide policymakers with novel ways to think about how to evaluate those trade-offs between equity and efficiency. And so in order to think about this, we proposed a conceptual framework. And so each of these gray circles in this figure represents a geographic area. And so what we can do is, using these geospatial derived measures of population density as a proxy for efficiency, and travel time to closest cancer center as a proxy for equity, we can start to map, using the word map maybe not be right here, but we can start to basically plot these different counties these different quadrants, where in the lower right, these would be counties that are exhibiting high population density and short travel time. In the lower left, these would be counties, sorry about that, counties with low population density and short travel time, which, by the way, we might consider to be suboptimal, because that's going to be very costly. That's going to be very expensive. And so the policymakers have to think about that. To the upper left, which would be low population density and long travel time, which is certainly efficient, but not great if you're living in a rural area. And so that's kind of got an equity concern. And then finally, this quadrant of high population density and long travel time. And that really, I mean, it's pretty obvious that you need to build a cancer center in a place that's got high population density where people are experiencing long travel times, because that's going to be both efficient, or that's going to be very efficient to do that. The other thing that this representing the data in this way shows us is we can get some insight from how steep this slope is, where the more efficient a health system is organized, the more closely the slope would lie across the 45-degree line here, the negative kind of slope. And the flatter that curve would suggest a more equitable distribution, where travel times are not necessarily longer if you're in a rural area versus an urban area. And these different colors I'll come back to. These are just, there's ways for us to identify statistically significant geographic clusters of these 4 different quadrants. And I'll describe how we do that shortly. So we had to corral a ton of data to do this, as you can imagine. And the first thing to do was to collect data on facility locations. And so there's a nonprofit called Global Oncology. They made this nice map, and they kind of track cancer programs in a lot of countries around the world. And so what we did was we kind of used that map to look up different cancer programs. And generally, these cancer research programs are going to be providing care as well. We did do some verification to make sure that was true. And these would be really high quality, kind of tertiary, like really kind of national referral center type centers that would be captured. For our analysis, we wanted to focus on 4 countries that displayed different approaches to rural healthcare delivery. And so the 4 countries we chose were Kenya, Malawi, Rwanda, and Tanzania. Rwanda and Tanzania, for those not familiar, are countries that have invested a lot in rural healthcare delivery. They've invested a lot in building facilities in these smaller villages around the country as kind of a first point of entry for folks presenting with any kind of symptom. And the idea is you go to these primary care facilities and then get referred up to the national level. And so these are countries that are very well recognized for having very distributed healthcare systems. Kenya and Malawi are less so that way. They also obviously have equity goals in their health policies, but they haven't been they haven't invested quite as much in those rural networks. In terms of population density, we were able to pull data from the World Pop Project. And so this data set is available on Earth Engine, I think. And so these, if you're not familiar, are essentially gridded population estimates with 100 meter by 100 meter resolution. And so the World POP project basically builds these models, pulling in a lot of geospatial sort of inputs like land cover, settlements from satellite images, and other contextual factors and uses random forest procedures and regression to basically produce these 100 meter by 100 meter estimates. And so we were able to pull this for the 4 countries I described. We also had to pull in a number of other geospatial data inputs in order to inform the estimation of travel time. And so land cover, I actually do think I pulled land cover and elevation from Earth Engine. Some of the other boundaries, I was working with some other colleagues who are more familiar with ArcGIS, which is probably a GIS tool that many are familiar with here. And so these have pretty high quality data on administrative boundaries, rivers and lakes as barriers for sort of traveling in geographic space, and then roads. And for roads, we use the Global Roads Open Access dataset from Columbia University, which is kind of a global database. It is, the time period on it is kind of variable, and there are, basically we had to do this trade-off of having global coverage versus high quality. And so at the end of the call, if folks have ideas about this, I'd love to hear more. In terms of estimating travel time, we didn't use Earth Engine. And so very late in the project, I actually realized that this procedure has been built into Earth Engine and would have saved us a lot of time. So unfortunately, when we started the project, we weren't aware of this. But what we used was the World Health Organization's Access Mod 5 tool. And so this does estimates of travel time, but also does a lot of other analytic procedures, geospatial analytic procedures related to healthcare access. And it's because it's a WHO sponsored thing, we decided to go with that. What Access Mod 5's geographic accessibility tool does is when we feed it in all of those inputs I showed you, the facility locations, population, all the different sort of land cover, water boundaries, roads, etc., it actually will spit out a raster with travel times estimated in 500 meter grid for the entire geographic area you're looking at. So you can imagine, like for an entire country, this is pretty amazing. That you can produce something like this. And so it does require a lot of assumptions to be made. And so the user has to specify the travel time for each of these different land cover types. So for example, are you going through a forest? Like how is a patient navigating through the forest? Are they biking? Are they walking? How quickly are they moving? And so the outputs of travel time are highly sensitive to those assumptions. For our analytic approach, we first just estimated straight Pearson correlations between district level averages of travel time and population density. And then we estimated the spatial correlation between the district averaged travel time and population density. And so the spatial correlation is accounting for the fact that neighboring units would be expected to look more similar with respect to these attributes that we're looking at, travel time and population density. And the statistical procedure that we used was the bivariate local indicator of spatial autocorrelation, which I'm going to summarize as LISA or LISA. And what this is doing is it's estimating the correlation between population density and neighboring travel times. And so I'll show you kind of what that means using a visual figure in a second, if that doesn't quite make sense. And what this allows us to do is to produce maps of district clusters classified by the 4 types of spatial correlation that very nicely correspond to the 4 different quadrants I showed you in our conceptual framework. We then can test for statistically significant clusters using permutation tests. And we did correct for multiple testing because effectively what's being done is this test is run on every geographic unit. And so because you have a lot of tests, you want to control the false positive rate. And so we did that using the Benjamini-Hochberg procedure, which is a way to correct for that. So going back to this bivariate LISA, and what am I talking about with sort of neighboring relationships, etc. Essentially, what we can do is we can produce 4 different kinds of clusters. And so in the first set of clusters, if we're interested in the geographic unit in the center, if that unit is high, The first type of cluster that's identified is high population density in the geographic unit of interest and long travel time in surrounding neighboring areas. The second type of cluster is high population density in the geographic unit of interest and short travel time in neighboring units. The third is low population density surrounded by longer travel time. And the fourth is low population density surrounded by shorter travel time. And so again, those four are corresponding to the quadrants I showed you in the conceptual framework. So what do these results actually look like? So we can make these are just plots to kind of illustrate the correlation between population density on the x-axis and district average population density on the x-axis, district average travel time on the y-axis. And we can see that the correlations in Kenya and Malawi, which, as I said, don't sort of have as strong policies in place for rural healthcare, have stronger correlations than Tanzania and Rwanda. You know, I mean, they're in the same ballpark, but they're slightly stronger, at least in Kenya and Malawi. Where we see bigger differences, though, is really in the spatial autocorrelation measures. So the bivariate LISA for Kenya and Malawi are 0.58 and 0.54, whereas for Tanzania and Rwanda, they're negative 0.29 and negative 0.31. And so that kind of aligns with what we thought, which is that countries that had invested more in these rural networks, and which applies also to cancer care, in thinking about placing cancer services in more rural areas, we're seeing kind of a flatter slope there and lower, less negative spatial autocorrelation. The other thing that we can kind of we should think about is this blue line is representing the 2-hour threshold. These units are in minutes, so this is 120 minutes, and that's kind of a benchmark for where you want facilities to be in terms of access. And so, you know, Tanzania, sadly, even though it's doing well on equity, in urban-rural equity, it's got a little bit of work to do in terms of making these services accessible, because most of the counties or most of the districts in Tanzania are displaying travel times in even urban settings that are above 2 hours. And so that might be something that, you know, and working with colleagues there, we've shared these data with them, that we want to think about a bit. Rwanda, everything is below 2 hours, and in part that's because Rwanda is a very small country. We'll see that in a second. And then Malawi also is struggling a little bit in terms of the travel times. So what's cool is we can also map this, and so we can sort of see where those statistically significant clusters, which I should mention do pop up in these figures too, but we can see actually where those clusters are located. So these are the blue and the yellow are more efficient clusters. The green and the purple are inefficient clusters. So in Tanzania, you know, the low population density, short travel time, maybe there's a lot of rich people there, I don't know, but also if they want to think about building new cancer services, this purple cluster down here might be an area to think about doing that. And in Rwanda, when I was saying it's a smaller country, you see that the scale here, you know, this entire scale is like 1 bar in Kenya, for example. So it has an easier time of getting everything within 2 hours than some of these other countries do. And so again, like the maps are so powerful because you can explain to policymakers, hey, here's a problem, and here's where you need to go if you want to think about doing something to resolve it. So what can we kind of learn from this study I just presented? So it does seem to correlate with what we thought, that countries that invested more in rural healthcare access displayed more equitable spatial distribution of cancer services. And the plots allow us to kind of see this in sort of correlation kind of context. And so they can be used to help benchmark against policy targets. If we want, for example, you know, some percentage of the population or counties or districts to be under 2 hours. And we didn't get to do this in our study here, but obviously it would be very powerful to be able to monitor these metrics over time. So if a country has proposed an equity goal, monitoring these metrics over time would say, hey, how are we doing in terms of achieving those goals? These maps allow policymakers to also identify the locations with inefficient or inequitable allocation of services. And so that provides a very powerful motivation to bring about the appropriate response. There are a number of limitations to this study, as with any study, and really the big limitations here are the estimates of travel time we're finding could be very optimistic. As I mentioned before, the assumptions that we're putting in are assuming that they're assuming that these patients are using the modes of transit and the speeds that we're proposing, and if those are incorrect, we may be wrong in terms of how fast or long it takes them to get to these places. And so it's really important to work alongside local colleagues, and so we worked very closely with folks in these countries to make sure that we weren't too far off with the assumptions that we were proposing there. So, okay, so we're kind of at the end here. There's just a couple of things I want to kind of leave you with, and so what I hope, what my takeaways from doing this, and what I hope some of the takeaways that you'll take from this presentation are, first, these geospatial tools like Earth Engine are really offering some novel insights into how we can think about addressing cancer disparities. It provides a very easy way for us to start to think about specific features of our neighborhood environments and link them in longitudinal studies of health, cohort studies, cancer registries, like I showed you, and we can, by studying associations between these specific modifiable neighborhood environmental characteristics, we can either think about informing a specific intervention around that that feature, or we can use that information, because it's location based, to identify where high-risk groups are located. And then in the second example, I showed how these geospatial tools are allowing us to estimate geographic access to cancer services and help policymakers consider the trade-offs between equity and efficiency when making policy decisions. And then the last really cool benefit of this is I've presented data from the US and data from Kenya, Malawi, Tanzania, and Rwanda. And so these data sources are available no matter where you are. And I think that that's a really powerful powerful thing that we can take and that we should kind of share with our colleagues working in low resource settings. So with that, I think I'll stop there. I have to acknowledge several smarter people than me who helped me think about these problems, administrative support from some of the institutions I'm affiliated with, the participants and governments who made these data available for these studies, and some of our funding. And with that, I'll take any questions you have. Thanks so much.